Okay, good evening, everyone. Thank you so much for joining us, whatever your time zone is. I know we've got people from 4 continents and about 10 different time zones joining us today. So it's 7:30 p.m. here in Manchester in the UK, and I'm delighted to welcome you to tonight's webinar on gastric physiology and function. This has been a topic that's been close to my heart for a long time, and I think recent advances in both the understanding of how the stomach works, the interventions that are available for people with gastric disorders, and the technology to investigate this function has made this very timely. And I'm delighted to have a couple of fantastic speakers to take us through this tonight. I'm just going to start off with a little introduction. So just to tell you a little bit about the Functional Gut Clinic, we've been around for about 10 years now. It's about 2013. And when we first started the Functional Gut Clinic, I think the question that many people asked was why functional? Because basically functional had become a byword for failure in gastroenterology. And really that's a failure to identify the cause of life-affecting GI symptoms in many patients. So it had many negative connotations. And that's mainly because existing tests examine structure rather than function. And we really wanted to reclaim the F word and make functional diagnosis the first positive step on the road to resolution for many patients. And what our mission really is to help identify and preserve normal function where possible, whether that's in the esophagus or the stomach, and then objectively evaluate abnormal function to help guide decision-making for our gastroenterology and surgical partners. And over the years, we've used an integrated approach. So, my PhD was in brain imaging and looking at gut function. So the brain is incredibly important as part of the functional diagnosis. But we also have to think about the function and physiology of the throat, the upper gut, the midgut, and the bidirectional neural connectivity between these regions, because all of these regions are talking to each other, affecting sensation, affecting function. So you have to have an integrated approach to make a good functional diagnosis. And over the years, we've tried to move away from just using gastric emptying. So about 10 years ago, 12 years ago, maybe, we brought Smart Pill to the UK, wireless motility capsule, and that's sadly now been put to one side, although there is another capsule in development that might help to replace that. We've developed a raft of home breath testing to make gastric emptying, SIBO testing more accessible for patients. We brought 3 CPM electrogastrography to the UK, which I think Ken is going to talk about, so we could start to look at gastric neuromuscular function more objectively. And most recently, we've looked at high-resolution gastric allometry, which is the next generation of EGG measurements to try and increase our understanding. So I think what I want people to think about now is where we were with esophageal physiology maybe 15 years ago when high resolution was coming through and impedance. I think this is where we are now with gastric physiology. And I'm absolutely delighted that the 2 speakers today are going to take us on this journey and explain how the stomach works, because I think a lot of us have forgotten how important it is, and then take us through the diagnostic pathways. So first of all, it's my great pleasure to introduce Ken Koch. He's a bit of a hero of mine. Every physiology paper I seem to reference back in my PhD days seemed to have his name on it. And I was delighted to meet him face to face last year for the first time and wanted to invite him to do this talk. So Ken's a gastroenterologist with a career-long interest in the pathophysiology of nausea, gastric dysrhythmias and gastroparesis. And he was an original member of the NIH Gastroparesis Clinical Research Consortium. He spent a career looking after these difficult patients, and he's currently the medical director and vice president of Entera Medical. So Ken, with great pleasure, I pass over to you. And just to say, if anyone's got any questions, please put them in the Q&A, not the comments, and then we'll answer those questions at the end of Ken's talk. Thanks, Ken.
Well, thank you very much for inviting me, and it's great to be here, and welcome everybody who is listening in. Yes, we're going to tackle in the next 30 minutes or so gastric neuromuscular dysfunctions in gastroparesis, diagnostic tests and treatments. So let's just get started. I think we'll go from this objectives here are to review normal postprandial gastric neuromuscular activities, and then the abnormalities that we know about in gastroparesis. We're going to consider the clinical usefulness of non-invasive tests. I'm going to emphasize the non-invasive tests for gastric emptying, gastric capacity, gastric myoelectrical activity in patients who have chronic nausea and vomiting, but they also have the other symptoms we associate with gastroparesis, early satiety, abdominal discomfort, and so on. So we'll review in general drugs and device treatments for the symptoms and where we are. And so let's just get started here with reviewing the normal work of the stomach after a solid meal. I would often tell my patients, the stomach's a workhorse, and it's also a muscle. And the thing is, it has three important functions. The first one is actually to relax the muscle. That is the fundic relaxation. It requires vagus nerve, nitric oxide release, but it isn't just the fundus. As you'll see with some slides later on, depending on the meal, we may want to relax the corpus and the antrum, especially in response to large liquid volumes. But the first order of business is accommodation. And then as pepsin and acid are being secreted, the fundus moves the chunks of food, which I show here as these green circles, moves those chunks into the corpus and antrum for milling or trituration. And this is a process where these chunks are milled into tiny particles, shown down here. And the tiny particles are in a nutrient suspension then called chyme. And when enough chyme is prepared, a peristaltic contraction forms and will express, if you will, the old timers called this antral systole, actually push, pulse 2 to 4 ml of chyme into the duodenum. So it can be assessed, you get the right amount of CCK, the right amount of secretin released for that particular nutrient suspension. This recurs over and over, right, during that time at the postprandial period. It requires antral pyloroduodenal coordination to accomplish that as well. So, liquids will be easier to empty than solids, and solids present quite a challenge to this neuromuscular apparatus of the stomach. But as was intimated, it's crucial. It's a crucial process, right? It's the way that we nourish ourselves. It's as important as sustaining the nourishment that supports life. And so it's crucial that it's paced. These contractions just don't happen willy-nilly. There's a normal 3-cycle per minute slow wave activity in the body and antrum. The slow wave was actually called pace setter potentials in the past, and they emanate from a pacemaker region on the greater curvature between the fundus and the corpus. Those signals go around the stomach and they migrate slowly, taking 20 seconds to get to the pylorus as another wave is making its way down the corpus. So this is just showing these slow waves. By the way, they are present because of the interstitial cells of Koch. We know those are the pacemaker cells. And studies by the NIH and Dr. O'Grady's group have shown that as you deplete ICCs, the pacemaker is not so strong. Problems develop, and it is the main cell that is depleted in gastroparesis. The fundus does not have so many of those cells, does not really have a rhythmicity. And so it's that 3-cycle per minute rhythm that we're looking for in the cutaneous electrogastrogram, which we'll both talk about as we go forward. So the slow waves are important, but the slow waves bring the circular muscle to the threshold of contraction. And it's the circular muscle wave. We see them in endoscopy, right? We're scoping. We can see a beautiful circular wave of contraction move over the scope sometimes towards the pylorus. And it's that circular contraction that does the milling or trituration and emptying. And to get a circular muscle contraction, there's plateau or spike potentials, action potentials that develop representing the depolarization, repolarization of the circular muscle. But the circular muscle has to be linked to this coordinating a slow wave or pace setter potential. And so, especially after we eat, we need that coordination between the slow wave and the depolarization, repolarization of the circular muscle. So the electrophysiology really, that's basically an overview of the electrical physiology that creates the moving peristaltic contractions that does the milling and the emptying. And so when you and I are enjoying a meal, well, we feel this prandial, postprandial, we feel full, but it's a comfortable fullness. We're pleased because we're getting nourishment. Our hunger is being satisfied. There's pleasure, happiness. When you're having a fine meal, you're not eating, you're dining, and it's sociable, and it's obviously one of the great pleasures of being alive, and especially during the holiday season. So in any case, we now know over the last 20 years, everything I've just showed you goes wrong in patients with gastroparesis. We know they have impaired fundic relaxation. They have a variety of dysrhythmias. Between the dysrhythmias and the discoordination with circular muscle contraction, there can be antral hypomotility, depending on the nitric oxide depletion. The antrum corpus can be contracted. It can also be dilated. The pylorus can malfunction. And these multiple problems, you can imagine, would delay the rate of normal gastric emptying to a test meal. And so when we see gastroparesis on our scintigraphy studies, my question was always, why? Why is this stomach delayed? And I certainly want to do an endoscopy to make sure there's no pyloric stenosis. But really, it's these other actions of the stomach that create the delay, and each one of them is able to send a very abnormal vagal afferent signal to the brain, and thus we have this myriad of postprandial symptoms because this peripheral organ is just not working. And as Anthony said, the brain needs to know this. The brain really, really needs to know what's happening in the periphery. And so this peripheral organ is quite disturbed. And so the problem has been that look at all the symptoms that over the years we have put on gastroparesis, the rate of emptying. We've put a lot of symptoms on this particular abnormality. And so you all know you have to work up nausea and vomiting. It's a lot of causes of nausea and vomiting must be worked up. The same with pain. But I'm going to talk about the patient that you're pretty convinced, you're very convinced that the symptoms are coming from the stomach. And so let's jump right into treatment for a moment because our treatments are pretty bad right now. Patients are frustrated, doctors are frustrated. And one US support group survey indicated about 5 or 6% of patients are satisfied with their current treatments. And I was involved in a lot of these drug trials over the years, and I guess we had a prokinetic hypothesis. And that was if we could increase the rate of emptying, just increase the rate of emptying of the stomach, that would decrease the symptoms. And so I guess there was hope back here in 1979 when metoclopramide was approved, and we sometimes use erythromycin. But, it's basically a roadmap here. It's a list of drugs which have either failed or had side effects or were taken off the market. Some really help gastric emptying, but they did not help symptoms. And so this prokinetic hypothesis has really not worked out. You could even say it's failed. Why is that? And in the meantime, we just try any anti-nausea we can get our hands on. And many of those in our NIH trials, at least a couple of these in our NIH trials, failed to hit the primary endpoint. And later we'll talk about pyloric and bioelectric therapy. So unfortunately, simply making the stomach work harder hasn't worked out. In this recent comparison of 25 randomized controlled trials with prokinetics and placebo, I mean, the top three, it's really hard to get domperidone here. It's a weak prokinetic. Clevopride, I think, is not available anywhere in the world. And then aprepitant is not really a prokinetic, but we do use it, very expensive here in the States. And you see, this mirrors what I just showed you. The prokinetics, it's not enough. It hasn't been good enough. And one interesting study, which I know most of you are aware of, is this NIH Gastroparesis Clinical Research Consortium study, where we simply said, let's repeat the gastric emptying at 48 weeks, along with the gastroparesis cardinal symptom index. And if we just look over here on this side at this baseline period, gastric emptying is delayed at 4 hours, and there's your GCSI score. And 48 weeks later, actually a surprising number of patients, when retested, had normal gastric emptying. And but on the other hand, their GCSI was no different. Normal emptying, still the symptoms. And the alternative is the converse is over here. We recruited people with normal emptying, but they had a boatload of symptoms. And 37% of these folks developed delay at the 1-year follow-up, and symptoms were about the same. So my interpretation, and what we talked a lot about, is many patients, not all patients, many patients go in and out of gastroparesis. And the symptoms are interchangeable no matter what their status is. So there must be other, and I'm going to say gastric neuromuscular abnormalities. These other abnormalities drive the postprandial symptoms associated with gastroparesis. So bear with me, we're going to talk about this a bit. And my thoughts I'd like to share and take a moment to say, should we learn something from the cardiologists? Our gastroparesis is basically stomach failure. It's failing to pump, it's failing to get the food out in the proper amount of time. And too bad the heart doctors, the cardiologists, didn't call it cardioparesis, but they called it heart failure. But, they didn't stop there. If they had stopped, but just they'd still be using digitalis leaf. But they knew there might be a systolic dysfunction, and certainly we know that as antral peristaltic dysfunction. But they learned about diastolic LV dysfunction. But listen, we have poor relaxation of the fundus and stomach. They have really dissected cardiac dysrhythmias, but we know there are gastric dysrhythmias untouched therapeutically. Coronary artery disease, very common in heart disease. Mesenteric artery disease, pretty rare, but does happen. Chronic mesenteric insufficiency can cause gastroparesis. They have valvular disease. This is an outflow obstruction problem. But we have pyloric valve stenosis, which we better rule out with endoscopy, but we now know there's a variety of neuromuscular problems in the pylorus. So you put all these together, and guess what? The ventricle, the LV function, the output can be very depressed. It can also be normal. And I would submit some of these factors are playing a role in delayed emptying, but also symptoms. But it may not be bad enough all the time to create an actual delay in the gastric emptying rate. Furthermore, we know for gastric dysrhythmias that ICCs are diminished. There's a macrophage problem, a chronic inflammation problem. We think the relaxation issue is vagal efferents, nitric oxide. We know that the pylorus can be poorly distensible. So you see, we're close, but we need to go further and put some of these ideas further together. And so when we think about gastroparesis, it's not just about beating the donkey with a bigger stick. There's more subtlety, as I've alluded to, with these underlying problems in the stomach and their vagal afferent, maybe even splanchnic afferents, carrying these messages to the brain where they are perceived as, I'm sick, I have a symptom. And what I perceive is nausea or discomfort or bloating. So I'm just going to talk about a few tests with the time we have today, but talk about electrogastrography. The physiology, we're looking at the myoelectric activity. We're wondering if there's a dysrhythmia present versus normal 3-cycle per minute rhythm. It's often, usually, I think, ideally combined with a test meal. So you can see a pre-post meal effect on the rhythm. And that's why the next part I put in here is provocative test meals. I've always been interested in just water load satiety. We'll talk about it, but subjects drink water over a 5-minute period until they're completely full. Not till they're nauseated, not to the maximum tolerated volume, which was used at the Ensure type liquid nutrient test, but we're looking for volume and indirect measure of accommodation. Our gastric, and by the way, solid tests can also be used. Greg will talk about this, or liquid solid nutrient tests together. These tests usually have a standard calorie, standard volume, and again, looking for gastric dysrhythmias and symptoms. You elicit symptoms in patients with these tests. The gastric emptying test we're aware of. It can be a breath test. It can be the more typical egg beaters nuclear test department meal. And here we're looking for a delayed rate of emptying. It's delayed, not delayed, global function. I'm not going to talk much at all about functional luminal imaging, but as you know, this will measure pyloric relaxation, distensibility, and then I'll look at dysfunction, neuromuscular dysfunction of the pylorus. So with these tests, we can actually measure those various aspects that I just pointed out. Let's look at dysrhythmias for a moment. I mentioned the ICCs are the major cell that's lost. It's the only cell that's really got significant decreases in numbers in gastroparesis patients. And so we know now that if you have 5 or more ICCs per high power field, you're going to be in a pretty good normal rhythm. And in this study by Greg's group, a mean of 2.3 ICCs in the gastroparetics. There were a variety of dysrhythmias, but also conduction abnormalities, and they really recapitulate the cardiac electrophysiology nomenclature. And so the stomach is that complex, it's that smart, but it can also become very disturbed when subtle abnormalities occur. Other studies have shown there's also decreased nitric oxide in patients with diabetic and idiopathic gastroparesis, and that would be then loss of some of that relaxation ability of the gastric wall. This is a single channel EGG. You might call it like a rhythm strip. And this is baseline and minutes here. And then the post-stimulation is the 10, 20, and 30 minutes after a water load, where a patient has 5 minutes to drink water till they're completely full. And you're looking very hard to see anything that looks like 3 cycles per minute. So it's a very dysrhythmic electrical rhythm in response to the water load. And then as you record patients, you're saying, whoa, what is different here? This is also a diabetic patient, baseline, and then just very strong, regular 3-cycle per minute pattern after the water load. And I'd have to say, this person has a normal electrical rhythm. But this person had very delayed gastric emptying. Is this electrical mechanical dissociation? Uh, that's a bad thing in cardiology. Or is this more of like aortic stenosis, where I've got a pretty good antrum, I just can't get it through. There's an outflow problem, like at the pylorus. So we looked at this approach with one of the NIH studies with large numbers of gastroparetics and functional dyspeptics, and about 2/3 had a dysrhythmia of some type, and about 1/3 had normal rhythm. But look at this. You see, Greg's group also showed that in patients with chronic nausea and vomiting and normal emptying, they can have decreased numbers of ICCs also. And I think this is kind of confirms that there are lots of patients with normal emptying who have a rhythm problem. And is that what's causing their actual symptoms? It's a neuromuscular problem related to rhythm. So you can break this down further. And if we just looked at the 1/3 of patients who had normal rhythm, they're not, one group had even a hypernormal. They were just like the one I showed you. That would be a hypernormal 3-cycle per minute rhythm. Others aren't quite so high in their amplitude. And then others are beginning to bleed in a little dysrhythmia, and you could almost imagine, they're on their way to, either a very low 3-cycle per minute rhythm, like the first example I showed you, or getting into these other dysrhythmic types. And we're going to hear a lot more about this in detail with the multi-channel recordings in a moment. So one way to look at this, we did it preliminarily, and this gets at should we begin subtyping patients, but we looked at 33 patients retrospectively. They had pretty severe delay, about 42%, but they had this normal rhythm in response to the water load. And we did Botox or balloon dilation. That was the treatment. And about 3/4 felt well. They even gained a little weight over the 3 to 6 months. But these are temporary improvements, but it is a suggestion that certain patients may do better than others, but we never looked at the dysrhythmic patients with this approach. So an idea there in terms of rhythm and treatment approaches. I want to take a moment to talk about the stomach relaxing in response to a liquid meal. It's an old study. It's using ultrasound. This is a healthy stomach fasted, and this is a healthy stomach 10 minutes after this 500 ml of soup broth. And I just want you to appreciate that it's not the fundus that's taking on the brunt of accommodating this volume. I see the corpus has liquid in it. It's distended. It has to relax. It's being stretched to some extent, right? And here's the antrum, and that's probably the pylorus right there. So the entire stomach fills up. And we use that as a nice visual, I think, for considering what might happen. And this is also a study in healthy people where a balloon was placed in the distal stomach, the antrum, and the same balloon in the proximal stomach or fundus. And then the balloon was enlarged, insufflated to certain pressures. And in the antrum, as the pressure was increased, the number of patients who said, I'm nauseated, increased to almost 80% of them. And there was electrical shifts in the EGG rhythm as well, whereas the balloon distension in the fundus did not cause or elicit that nausea. And so when I think of the water load test over 5 minutes and people drink, well, healthy subjects drank around 550 ml in 5 minutes and they feel full. That's it. They don't have nausea, they don't have pain, they feel full. But in this NIH study, you know, this would have been about 557 here, and 240 ml is 2 standard deviations below the mean. And so almost 26% of our gastroparetic patients felt completely full, and they had lots of symptoms with 240 ml ingested. But to me, that's a very non-distensible stomach. On the other hand, some of these patients with gastroparesis were, drinking 700-800 a liter. I said, wow, is that a different phenotype? Is that just a big floppy stomach? It's just taking on volume like that. And again, to not leave out our functional dyspepsia patients, 19% of them could not drink 240 ml, and they were totally full and have symptoms. So these two groups are extremely closely related, in my opinion. And sometimes they have delayed emptying and sometimes they don't, but they both share considerable pathophysiologic similarities. And just a quick note here that we just looked at patients who could not drink that 240 ml. They just, that's when they were full versus those who were intermediate, 238 to 4 or over 300. And I guess the point here is, these folks come in feeling more nauseated at baseline. They drank very little water, but they're totally full. Their nausea scores are elevated and sustained elevation. And so I think a combination of stretch, or you want to call it lack of accommodation, plus dysrhythmia is a recipe for nausea after the water load test. So at endoscopy, this is a tough test. One can do it. I'm not going to go into this endoflip measurements, but I'm just saying we can measure almost all the different aspects of the stomach dysfunction at this point. And I just want to point out that many of our patients have, other severe and refractory symptoms. And so if I couldn't get my patients' GERD symptoms any better with typical therapy, I would move to manometry and pH to prove the extent, the severity of the objective findings, the LES pressure, so on and so forth, to try to understand better what I needed to do here. Some of my absolute most refractory GERD patients had gastroparesis and some of those, and more obstructive kind of symptoms. Bloating, is that symptom from the stomach, small bowel, or colon? So a breath test would help get me an objective marker here to perhaps change my treatment a bit. And then we're hearing more and more, and it's certainly true in my practice, constipation is rampant when you can't eat properly. You have gastroparesis. And when all your medicines are failing, it's helped to be able to, it's not just constipation. It may be colonic inertia. There may be an anal rectal motility problem. And so physiologic tests will help make a mysterious refractory case quite understandable. What I would sometimes say, to a patient, I need a 6-pack. It's a 6-pack of tests. Literally 6 to 8 physiologic tests. So I could explain to myself and to the patients the esophageal physiology, stomach physiology, some small bowel, colon, and then I would review their symptoms, you see, with these physiological test results in hand and begin to sort out where their symptoms were coming from and often it helped direct my therapy. So back to therapy, meds, we got to try them. You try them for a while, and sometimes you hit the bullseye, but we have to move on to more therapies because the symptoms are refractory, and we don't give up. We don't say go away. We don't say go see somebody else. We try to understand the symptom and treat. So with this wasteland of medicines right now, with nothing really good, interest, of course, is pylorus and devices. And talk a little bit about the pylorus, and it's usually Botox or balloon. And that can be a trial, or more advanced will be the GPOM or the pyloroplasty. Not going to go deep into this, but a meta-analysis of about 10 studies, 482 patients. There's the range of who they were. Pooled clinical success defined as 1-point decrease in GCSI. Success of the GPOM after 1 year was 61% and lower than the short term, the 3 and 6 month results. Some adverse events, and only one paper with a 4-year follow-up at this point. Loss of response, loss of symptom response was about 12.9% per year. And so, again, it's like it starts out well, but there's a drift lower, and those of you who do GPOM may have a similar experience, but this is what I hear and what at least this one paper showed. And if pylorus is the therapy, and if there is a poor distensibility and there's an inhibition of flow, GPOM will increase the distensibility of the pylorus, but of course it doesn't affect the hypomotility or rhythm problem or impaired fundic relaxation, which may be really driving the symptoms. So a word on gastric electrical stimulation. This is the Atera product, which is 2 electrodes are implanted 9 and 10 centimeters from the pylorus on the graded curve, perpendicular to the longitudinal muscle layer. Here's the electrode. It's in the muscular wall, anchored there so it won't move. And endoscopy is done to make sure that there's no electrode perforated or in the mucosa. It has to be repositioned. And once that is checked out, then the device can be programmed with a number of parameters. And I just want to show you a US study. It's the biggest US study from Washington University in St. Louis. 157 patients. There's their GCSI scores for nausea and vomiting, and at 1 year, significant reductions. And it's sustained out to 5 years. So this is sustained help with these refractory symptoms. In this study, a lot of the other symptoms were improved as well. Also improved, medication use decreased, hospitalizations decreased, and this is, of course, what we look for. The patient was satisfied with their symptom relief, 87% and 80% at 5 years. So this is really wonderful for the patient, wonderful for the doctor to see such kind of relief. And we would like to know more about how it works. And 10, 12 years ago, there were studies, some improvement in the barostat relaxation measures after GES, gastric electrical stimulation, a little bit of data on improved rhythms, moving towards normal 3 cycles per minute, a teeny bit of data on change in ICC cells. A thought is there's vagal afferent traffic that is changed with GES. And as you change the sympathetic, parasympathetic balance, there's changes in the brain. there's a cholinergic anti-inflammatory pathway. So we have a lot of different ideas to press along these mechanisms of action with electrical therapy for these refractory symptoms. So final slide really is about, in the advanced or the invasive treatment approaches to refractory symptoms, gastric electrical stimulation or neuromodulation. Is it stomach, vagus, CNS modulation to help the stomach itself function better? There's minimal tissue damage. It's reversible, and you can titrate these electrical settings. The G-POEM pyloroplasty approach, the pylorus is transected to reduce pyloric resistance to flow, will increase emptying. It is irreversible, and so I think that's a concern. Some groups do those two methods at the same time, GES and a pyloric procedure. And then I think others do a sequential approach. At least when I was at Wake Forest, our surgeon wanted to do the GES initially, and then if optimization of the device and we couldn't reduce the symptoms, then consider a pyloric therapy if the symptoms that were remaining were thought to be due to pyloric dysfunction. So I covered a few things here tonight. The stomach is amazing, sophisticated neuromuscular organ that receives, mixes, and empties the food we eat, process that sustains our life, and also sustains the pleasures of satisfying hunger, the drive for hunger, and the comfort and joys that go along with finding food. But diseases, I'm going to call them diseases, disorders of gastric myoelectric activity, relaxation, contraction, pyloric function may result in stomach failure, but may not result in actual delay. But I'm suggesting that these other issues may be more relevant to the debilitating postprandial symptoms our patients have. So the treatments for gastroparesis based on the prokinetic hypothesis have basically failed at this point, and other gastric neuromuscular diseases, as I mentioned above, are objective therapeutic targets that I'm suggesting here tonight. And finally, physiologic testing confirms or rejects our clinical hypotheses and assessments as we try to treat our patients' symptoms, providing objective information that can, and I certainly hope will, lead to more rational and successful treatment approaches. So thank you. Thank you very much for attending tonight, and I'll turn it back over to Anthony.
Thanks very much, Ken. That's an amazing tour de force there. We just got time for one question that's come from Maria Aruda, which I've attempted to answer. We've got quite a lot of upper GI surgeons here, and one of the things that spooks upper GI surgeons about doing anti-reflux surgery is gastroparesis. But actually, you need an intact hiatal complex to create kind of pump function to get the stomach emptying, and sometimes anti-reflux surgery can improve gastroparesis. Do you have any comments on to our upper GI surgeons about how they should treat people with hiatus hernias and minor delays?
Yeah, minor delays, you may actually help them, because this, I think, for the foregut surgeons and the gastros interested in reflux, I don't think we've given any real serious thought to the fact that that weak or intermittent LES, as it opens up inappropriately, is really has to inhibit the effectiveness of a peristaltic wave. And so that upper sphincter in gastroparesis, I think, is a really important area to investigate. And then all gastroparesis is not the same, right? 15% remaining at 4 hours. Come on, that's you emptied 85%. That's not a really, really weak stomach. And then on the other hand, if a really tight pylorus and a really weak LES, you're going to have lots of reflux because the LES is the least path of resistance. So, Anthony, those two sphincters, bridging a complex stomach, I think is really ready for more detailed thought and dissection of.
Yeah, and we certainly, when we use the 3 CPM technology, you can see how the 3 CPM activity dies away after the water load in patients with postprandial reflux because it just can't seem to get that pump action. So we often look at that in conjunction. I've just got one more question from Simon Dexter, who's a upper GI surgeon in Leeds. He's asking, is pyloric dysfunction isolated or part of a broader antropyloric problem? Are there different phenotypes basically involving these two?
Yeah, I think that's a great question because I I don't see why there couldn't be a continuum. Sometimes there's just lower esophageal sphincter, hypertensive sphincter, but there's good peristalsis in the esophageal body. I think we need to do more like endoflip in patients with normal emptying, but all the symptoms. Could there be good rhythm, good accommodation, normal emptying, but just a pylorus that's like that?
Yeah.
So in the spectrum of pathophysiology, someday we'll get to a point, just like the cardiologists do, you have heart failure, they're going to do the coronaries, they're going to check the valves, they're going to check the rhythm and come up with a coherent game plan.
Well, I think what we need is a more sophisticated way of looking at gastric rhythms, which sets Greg O'Grady up very nicely. So if you can just stop sharing, Ken.
All right.
We rehearse this, guys. If I can just introduce Greg. So, Greg, thanks so much for joining us from New Zealand. I'm not sure what time it is there, but I'm sure it's horrendous. But you're in the next day, aren't you? So Greg is a professor of surgery at the University of Auckland. He's co-founder of and CEO of Allometry. He's a key opinion leader from GI physiology and diagnostics and has got over 200 publications in the field. And his work has focused really on developing and translating Allometry's high-resolution mapping for technology for looking at gastric function for people with chronic GI symptoms. So yeah, if it's got up, yeah, that's all working well. Greg, if you can come off mute, you'll be good to go.
Thanks, Anthony. It's a pleasure to be here. It's Friday the 13th over here already, and it's a good time. It's 9 a.m. in the morning, so it's a pleasure to be here. Yeah, so wonderful to join this seminar. I'm going to be talking about non-invasive assessment of gastric function, and particularly work we've been doing here in New Zealand, developing a new non-invasive test called gastric allometry, which is Anthony's introduced as a high-resolution approach to non-invasively measuring gastric function. And I'm going to talk a little bit about the background to that, the philosophy of why we've developed it and some of the technical steps to get there, and then show you how the test works and talk about a couple of example papers. So as Ken has already very well introduced, these symptoms that we face on a daily basis, whether as surgeons like myself or gastroenterologists, are really challenging to diagnose and treat. And it's really one of the last areas of medicine, I think, where we have a very poor understanding of linking symptoms to mechanisms and treatments. So that's the motivation for this program of work we've been doing to try and build more clarity around this field. And really, I think the field has probably reached a state of peak confusion at the moment. It's just, I think, been getting worse in recent years. Part of it's been the kind of gaps that have been identified in gastric emptying, but also our inability to robustly define these symptoms and their mechanisms. And so we're left with a state where these disorders all seem to overlap. We're really not sure what to call them, whether motility disorders, neuromuscular disorders, or disorders of gut-brain interaction, and whether they're a spectrum of disease. And so I think the future's bright. We'll get there, but it's currently a phase of quite a lot of confusion in the field. This is a study that was from Auckland, but is reproduced in both the UK and the US, that at the moment with patients with nausea and vomiting, it's taking over 5 years to reach a definitive diagnosis in general out there in hospitals. And patients are having repeated tests, often the same tests over and over, trying to get conclusive answers, 3.6 tests per year. And 40% of them are receiving excess radiation, which I think speaks to some of the difficulty we all have in diagnosing these patients well to direct therapy. And again, I think it comes down to inconclusive tests. And Anthony said this in his introduction that a lot of the tests we have for structure in the gut are, of course, very good and very mature around endoscopy and imaging tests we have. But for function, we're still really behind. We have gastric emptying and that Ken has talked about at length. And manometry is kind of a difficult, more invasive test that's quite difficult to interpret and not commonly available. Just Ken's already talked about this study, but it was really a landmark that they performed, and I'd like to just mention it again. This great work from the GPCRC that really showed the lack of reproducibility of gastric emptying and its lability changing category at 48 weeks, which Ken showed the slide on. Its inability to correlate well with symptoms, and it really doesn't correlate as well with these neuromuscular pathologies of ICC loss and these important changes we know occur in some patients. I still think the test is useful when it's positive. When it's negative, though, I don't think it adds a lot to our management. When it's positive, we at least know that there's something wrong with gastric motility and it may point to something. But when it's negative, I don't think it's very contributory just because we know that patients, as Ken said, duck in and out of this state of delayed gastric emptying.
Greg, could I just ask you to go on full screen? It just seems to have gone to layout view. Possible. Perfect.
Is that better?
Yeah, that's great. Thank you.
Ah, thanks. Yeah. Okay. Yeah. So as Ken said, that relationship with gastric emptying is really because it's a non-specific test of gastric function. Delayed gastric emptying can be caused by a number of factors in the stomach. We've talked about the pylorus, the lack of pump or good neuromuscular function, the vagal innervation that you need, and of course the accommodation. And so not only is it non-specific, but it really doesn't get to a specific cause of gastric emptying that can guide therapy. So I think the future, and this is where we want to head, and I'm very aligned with both Anthony and Ken on this, is that the future is going to be through mechanistic profiling of gut function, really getting beneath the symptoms into the physiology and the work that the Functional Gut Clinic and others are doing to better define where these symptoms are actually coming from so we can lead to more targeted approaches to treatment. And this has to be the future of this field, moving out of just symptom descriptions, moving away from solely doing gastric emptying testing to multimodal testing so we can really understand the cause of individual patient symptoms and guide therapy. This slide shows the sort of places that these symptoms can come from, acknowledging it is complex, as all medicine is. The symptoms can arise from a number of areas. You can have centrally mediated disorders, autonomic disorders, accommodation, and then the neuromuscular disorders that Ken has introduced as well in pyloric. So what we've been doing is really to try and develop more specific tests to discriminate between these symptoms. And I do feel like we're making a lot of progress in this at the moment. It's been a time of I think, rapid development in the recent years. So we've been very focused on this activity that, again, Ken introduced with the myoelectrical activity. The stomach has a pacemaker here on the greater curvature. It sends out these waves every 20 seconds that go down the stomach. And then at the end of the stomach, when they finally reach the end here, there's a very rapid acceleration into the pylorus. And these are driven by this really interesting cell, the interstitial cell of Cajal. Many of us know it more from GIST tumors, but it is, of course, the electrical rhythm pacemaker in the gut. And a really important cell for the whole gut, particularly the stomach. This cell and this activity have, of course, been known about for a long time, since 1922. This guy, Alvarez, who found this activity, had a little prophecy that he wrote about in JAMA back then, saying that gastroenterologists would come to rely upon electrical measures for the routine diagnosis of stomach disorders, just like heart specialists. But it never really has come through to widespread adoption yet. But I think it's now at the cusp of that due to a lot of good work by the likes of Ken and others developing the technology through. And then I think a technological leap that's recently happened with the high resolution systems. And again, like Ken, we point to the development of cardiology for inspiration in developing these devices and the way they've led these high resolution mapping technologies that have given a much greater level of discrimination about what the heart does. We can apply these techniques to the stomach. So our lab in Auckland started out picking up cardiac electrodes and putting them all over the stomach during surgery of patients. And we were able to, through this exercise, really map what the basic patterns that the stomach made were. These were patients initially who were healthy, having liver or pancreatic surgery. We were able to get in and map their electrophysiology in really high resolution using hundreds of electrodes and generate a good idea about what the stomach looks like normally. You can see here in this pattern here, these waves look very regular. They're flowing down the stomach in a highly coordinated fashion. They're about 6 centimeters apart and they come every 20 seconds. So compare that to these patients. These were patients having the anterior device inserted at the time. And they showed this one, for example, normal activity coming down initially, but then it becomes highly irregular. These are some of those complex dysrhythmic states that occur in the stomach. It's actually a really interesting organ. It's capable of doing these complex behaviors. See, this is now highly irregular. These are patients with idiopathic gastroparesis or just chronic nausea and vomiting syndromes. This one had diabetes and advanced type 1 diabetes, and you can see here that this is severely dysrhythmic, and any resemblance of rhythm has completely fallen apart in this patient. So we did this interesting research, and we were able to say that the stomach is hiding a lot of significant pathology that we can't get at clinically, and so we needed better tools to understand it. And we also linked this to states of loss of these interstitial cells in the stomach. We have these important interstitial cells here shown in red and controls. You can see these beautiful longitudinal ICC in this section here. We're being depleted and haphazard in the patients with chronic nausea and vomiting and gastroparesis, regardless of gastric emptying state. So you see here, if they've got gastroparesis with delayed gastric emptying or chronic unexplained nausea and vomiting, their states of ICC were in general reduced compared to controls. However, this is not all patients. This is a subgroup who have these important dysrhythmic states and really represent, I think, quite a severe subgroup with true neuromuscular dysfunction. This was in a research context and obviously a little too invasive for regular clinical practice, but we felt it was something really important diagnostic gap that was missing from GI practice. And so we've been working over the last few years to develop a way to bring these devices into the clinic. We started, just to show you the roadmap, initially with laparoscopic approaches using coiled arrays, again, similar to cardiac catheters. We tried balloon catheters endoscopically, still quite invasive and quite unsatisfactory. But then we had a breakthrough. A colleague of mine, Armin Garaband, started working on non-invasive technologies for the gut, where we could get high resolution of electrodes, initially with small numbers, and then increasing numbers of electrodes. We found better results with higher resolutions. But this was, again, in a research context, 100 electrodes placed all over the abdomen, and you can see the complexity of the wires, and this was really impractical for clinical use. So through the COVID years, we worked on a project to develop a way to make this scalable and useful for clinics. And so we landed on this high resolution screen printed technology. And just like you screen print t-shirts, you can screen print electrodes using conductive inks. So we were able to screen print these on conformable materials that you can stick onto the abdomen, and then get a really simple high resolution approach to recording gut electrophysiology. And just to point out, these signals are really weak. They're about 100 times weaker than the heart, about the same as EEG for the brain. And so our philosophy has been, if you use a large number of electrodes, you can really pull out that weak signal and reduce the noise to get a good picture of what the stomach is doing. We built a device to capture that high resolution electrode data as shown here, and we named it Gastric Allimetry. It's kind of a telemetry system for the alimentary tract. So Gastric Allimetry is the name of the product. And we've been really delighted to partner with the Functional Gut Clinic and being the first to bring this technology to the UK, and now applied it in, I think, a very large number of patients. So I think well over 100. So here's the device. I'll show you a video of how it works, actually, so that you can see. Patient comes in, basically the same preparation for a gastric emptying test, and fasted. They stop pro-motility medications before the test in order to get an accurate read. And then it takes about 10 minutes to set up in the clinic. It's pretty quick. We prep the skin, we shave if it's usually males, and then we easily stick the array on. And then the patient sits in a comfortable chair, and we have an app so that they can record their symptom profile during the test. We stimulate the stomach with a meal, a test meal, in order to provoke symptoms and provoke gastric motility. And then we're able to record that for about 4 hours, which is the same as a gastric emptying test, so that we get a full cycle of gastric meal emptying. At the end of the test, it's easily removed. See this array here is taken off, and this reader is cleaned, and then we send back a report. This is what the symptom capture display looks like here. So it's been highly validated to be a robust symptom reporting tool in itself. And this is one of the things that clinicians probably find just as useful as the physiology, getting a really reliable symptom profile of the patients, because often that's quite difficult in the clinic. A lot of patients may be poor historians or not able to accurately display or separate the symptoms and relate them to a meal. And so by doing this in a digital tool with an app, we've found it extremely useful to get a clear symptom profile. Just to show you how this is useful, I'll show you some examples of the sort of symptoms that we get through these reports. And I'll step you through what you're seeing here. So draw on this here. So you can see here, this is where the meal occurred. This is a 4.5-hour test. So this is half an hour fasted here and then 4 hours after the meal. And the patients log in their symptoms every 15 minutes where one of these bars are here. The app tells them to log. And so what you see here is 3 examples of different symptoms. You see the one on the left, the pattern here is that they really didn't have any symptoms fasted. And then when they ate, they developed these symptom curves that go up and go down. And we find these symptom curves really important. You can see this one here. It's highly meal responsive. They get postprandial distress, and then it decays away as the stomach empties. So we know that this correlates with gastric activity, and these symptoms are likely to be coming from the stomach. And this is the part of the report output that the test gives. If you compare that to this one, for example, where they've eaten the meal, but it's really the symptoms are just continuous, going through continuously. Nausea, that is, this is bloating and pain. Really no relationship to the meal, and they're not decaying with time. If you compare this to a third example where they've eaten a meal and these symptoms are trending upwards as the test goes on. So we think these ones, where it's trending up late, it's a delayed onset, it's more likely to be related to the small bowel. When the stomach empties into the small bowel, these symptoms are driving upwards late in the test. So these patients, you can tell from the relationship, the timing to the meal, how these patients are related, their symptoms to gastric activity. More gastric profile, more small bowel profile, or a continuous pattern where it doesn't seem to be related at all to gastric motility. So take those off. We also do during the test a mental health profile, because a lot of clinicians tell us they want a robust profile of the patient's mental well-being. And so we've included this, a validated mental health screen, into the app as well. So when patients are sitting there doing it, we'll do a depressive stress and anxiety screen. These are not diagnostic of depression or anxiety, but they do give a significant indication about whether it's concern in the patient. And they've been validated in association specifically with patients with gut symptoms. And this can be really helpful, particularly when the tests are normal or they've got those continuous symptom profiles, and you're wondering whether this may be more a psychological problem than a GI problem or an overlap, then this can be helpful to help direct that management. So to show you some of the physiology coming out of the test here, this is what the physiology looks like in an example case. So you see here during this test here, fasting is pretty quiet. And then when they eat a meal, you get an increase in the activity. This is the amplitude goes up with the meal and comes down. And you see that again on the colored display here. It's about 3 cycles per minute in this case, which is that normal frequency of the stomach. It's really bright, and then it fades away once up to 3 hours once that meal's been completed. And so this is a typical example of a normal stomach profile in response to a meal. And just compare that to one like this one, this next case, which is a patient who has gastroparesis. This one here, where it's extremely irregular and scattered. And this is an example of a patient who's really not generating any reliable activity at all, and it's extremely irregular. So just to compare those two. We've developed a reference range for the test and 4 key metrics that can be applied. And these are the rhythm. Again, it's similar to cardiology, as Ken said, which we all know well. But the metrics we get are really the rhythm, the frequency, and the amplitude of the stomach. And we adjust that amplitude for the BMI of the patient, which has a significant effect on what's picked up from the electrodes. We also do a response to the meal, which is called the fed to fasted amplitude ratio, so how that amplitude increased with the meal. And through these metrics, we've, in 110 healthy people, developed a reference range that shows normal ranges for the rhythm, the frequency, and the amplitude. So looking at this example of a patient with a really irregular test, we look here at the rhythm, and they've got a really disorganized rhythm of 0.05. The rhythm should go from 0 to 1 as an example, and here it's only 0.05. It should be more than 0.25 in the reference range. So that's how those reference ranges can be applied in this case to show that this patient has a really poor rhythm, well below the reference range that would help point towards a more neuromuscular disorder as the basis for their problem. All right, so just to point out again how this works. So why is it looking so disorganized? So these are the patients that we think have the loss of these ICC, and they're getting really irregular states in their stomach, on their stomach. If you measure directly on the stomach, you'll get these highly disorganized wave patterns, and that's translating into these in the body surface when we do the non-invasive measurement, a really chaotic looking signal with poor rhythm. So that's one group that we've been able to pull out with the device, and I'll show you a couple of others that the device can be useful for in these patients with otherwise undifferentiated symptoms. So this is an example of a normal test here. So what you're looking at here is this this patient. It's up here. So yeah, this patient has a pen working. This patient has a low amplitude after the meal. They eat and it goes up and then it goes down, and that's a very normal looking trace with normal reference ranges there for their activity, really strong activity, good 3 cycle per minute, normal frequency, normal rhythm, normal amplitude. But what you see with their symptoms is they've got one of these symptom profiles where they're merely meal responsive and then it decays away after the meal. And these are the ones that we feel that we have shown to be correlated between the symptoms and the gastric activity that we think have a more sensory motor profile. So they have normal gastric function, but they're getting very heavy symptoms straight after the meal that correlates with when the gastric activity is occurring. And we show these correlations through these graphs showing that all of the symptoms here are correlating with between the symptom and the gastric amplitude on these scores, greater than 0.5 being a strong correlation between these events. So the test is able to give us a correlation between the gastric motor activity and the symptoms, which helps us to diagnose whether the patient may have a sensory motor disorder. Okay, so to show you another example, compare that then to this case with continuous symptoms. So what you're seeing here is again a normal test. The patient has a regular frequency, rhythm, and amplitude, but they're getting almost continuous symptoms. So their symptoms are occurring regardless of when they're fasted, whether the stomach's working hard, or whether they've finished the meal. And so you're getting this strongly continuous symptom profile that doesn't show any relationship to the gastric amplitude. And from multiple studies and well over 400 patients now, we know that these patterns tend to be highly associated with anxiety and depression. Seems to be that these ones tend to be diagnosed more common clinically with anxiety states, depression states. They're more likely to be on medication for these disorders. So true anxiety and depression states, but also in our app, we show higher relationships with anxiety and depression. So for whatever reason, patients with continuous symptoms and normal tests seem to be a group who show more disorders of gut-brain interaction. So what we've been doing then with these different phenotypes we pull out of the test is to try and build different patterns or phenotypes that we can put the patient into for a mechanistic diagnosis. I've talked about the continuous profile, some of these sensory motor profiles where it's more of a hypersensitivity disorder or accommodation, and these neuromuscular ones where we focus more on the ICC loss and the problems with contractions. As well as that, we've been able to add a few more phenotypes recently. Ken talked about ones with sustained high amplitudes that their group have done a lot of work on, and these ones having suspected gastric outlet resistance. And we thank Ken for introducing that idea. And then these late onset patients who have the small bowel type profile where they have normal gastric function, but the symptoms occur late, may be pointed towards a small bowel disorder, and they might go on to have breath tests or imaging to exclude obstructions. And then we've got a really interesting group for the surgeons who we've shown have high frequencies and often seen in association with vagal injury. There seems to be a new finding that if you're getting a severe vagal injury, the patient gets a high frequency activity. This is one that we're watching really closely at the moment that's emerging that could be a strong link to vagal injury, particularly a surgical injury or long-term diabetes, and I'll show you some data. So just in the couple of minutes left for this talk, I'm going to show you a couple of papers to really demonstrate how these tools can be used to put patients into definitive subgroups in order to direct management. So this was an example of a paper we did in chronic nausea and vomiting syndromes, and the aim here was to identify subgroups of disorders who are otherwise very difficult to put into a disease classification. So just to show you what the control graph looks like, hopefully familiar by now, you get a significant increase in amplitude after a meal, and then it decays over time, over 3 or 4 hours, and a normal frequency of around 3 with a regular rhythm. This was a summary of 43 patients. When we looked at the matched patients to the controls, they really fell into 2 clean groups in this study. About 2/3 of them had normal activity close to the controls, and about 1/3 of them had severely disrupted rhythms and really low amplitudes. And so the study, we were able to show that by doing the gastrocalorimetry test, we could break out these patients into those with true neuromuscular problems who we believe have ICC loss and dysfunction versus those who have normal gastric activity and their symptoms may be coming from another aspect of gastric function or from the brain-gut axis. And this study showed a correlation then between the patients with abnormal gastric function and their biomarkers that correlated with their symptoms. So those with worse rhythms had worse symptoms. And those with normal activity correlated strongly with health psychology. So these ones who had normal activity, especially the continuous patterns, tended to have worse anxiety and depression. So that shows one example of how the test can discriminate symptoms, patients with symptoms into groups with abnormal gastric function or normal to guide therapy. I want to show, particularly for the surgeons in the audience, this is a common question we get. What's the impact of sleeve gastrectomy on the stomach? So obviously in sleeve gastrectomy, you take off the pacemaker altogether, and it's a really massive insult to the gastric conduction system doing this. And a lot of the time, the stomach's quite resilient, but we really don't have any awareness of when we do this operation, what effect it has on gastric pacemaking. So we did this study in New Zealand recently in 21 patients with sleeve gastrectomy. And what it does is it significantly drops the gastric pacemaking rate and regularity after the surgery. This is the dominant frequency drops from about 3 to the range of about 2.2 to 2.6 in patients. So what's happening here is that the pacemaker is really moving from a site here on the greater curvature. It moves over to the lesser curvature, but also becomes less stable and kind of jumps around quite a lot. And we're starting to see that patients who have worse remodeling of the gastric conduction system after sleeve gastrectomy, be it lowest frequencies or worst rhythms, really weak activity due to the remodeling, can have worse symptoms associated with that. And this is kind of an emerging area that we're looking at the moment. I'll show one more study here from patients who've had fundoplication. This is another area of significant interest to surgery where the device is showing a significant emerging utility. So these were 16 patients who had persistent severe symptoms after fundoplication, and they underwent gastric mapping in order with gastrocalorimetry to define where the symptoms were coming from, and it was just published this year. Really, the key finding from this study was that they fell into 2 groups, these patients. They fell into groups with really abnormal gastric activity here who had worse symptoms. This is the total symptom burden score on this axis, and on the groups at the bottom are the ones with the even abnormal gastric function tests over here, whereas this group had normal gastric function and reduced symptoms. And the types of abnormal gastric function we saw, there were 2 groups. There were those with the irregular, unstable activity who may have just been pre-existing before the fundoplication actually, that they had this. I don't think the fundoplication is causing this kind of neuromuscular insult to the stomach, but as some of them came through, they had severe symptoms afterwards, and it just showed that they had a rhythm instability. But the other group were very interesting, and these ones had a vagal injury, either documented, there were some that we knew had one, that were documented at the time of the procedure. And 3 of them here who had a documented vagal injuries all had very high frequencies in the test, and they all had the worst symptoms. So there was a good correlation between the total symptom burden and deviation in frequency. When those frequencies went high, they tended to have a higher symptom burden. And this group, I don't think will respond to any repeat surgeries or revisions. They're just a group who have unfortunately had a vagal injury. And so the test is showing the ability to pull out the patients who've had these vagal injuries versus other causes of symptoms, which might be more sensory motor, or related to pre-existing conditions like poor rhythms, maybe from associated neuromuscular disorders. Lastly, we have done this in diabetics. It's another common question we get. What about long-term diabetics? And this is the last study I'll show, showing that they fall into the same sorts of subgroups that I just showed you. Long-term type 1 diabetics can get high frequencies. And again, we think this is driven by vagal neuropathy and a very strong association between symptoms and the frequency deviation again. So when patients are getting these frequencies driven up over time, from long-term diabetes, this group tended to have peripheral neuropathy as well. They were well-established diabetics who had multiple end organ complications, who had the high frequencies, and there was a strong correlation between the symptoms and the degree of frequency deviation that we saw in the study. And there are a group of diabetics who also lose ICC. The diabetes can be damaging to ICC and result in ICC depletion, and those ones will develop abnormal rhythms. That can recover with good glycemic control. And so this is important to distinguish the diabetics who may have high frequencies versus those who have a more recoverable state of gastric damage, neuromuscular injury, where if they have good glycemic control, we expect the rhythms to recover over time. And then some of them had normal activity who tended to have much lower symptoms. So hopefully in summary, you can see that we're building at the moment a gastroinflammatory phenotype map. I think as Anthony said, it's a very exciting time for the field. We've been able to make a lot of progress with the high resolution devices, really starting to put these patients from a discriminate group of symptom labels into more specific disease boxes where we can look at the physiology and accompanying with other tests like gastric emptying and breath tests that are done in order to really profile out which patients belong where in order to direct management. So that we see that we can put labels on the patients. We're starting to put labels, this is still emerging, for specific mechanisms linked to specific physiology profiles. And I think this will be the future. So yeah, thank you very much. I'm looking forward to any questions.
Thanks so much, Greg. It's amazing as always. We do have some questions here. I think I'll go to Louisa Keane, who is from Sheffield in the UK. She's asking, is there any data in pediatrics at the moment?
There is, yeah, there's two really good studies coming out in pediatrics, and it's got regulatory clearance for adolescents, so that's 12 and above. It's not yet validated in under 12s, but some clinicians are using it off-label.
Are
But
there any
for
differences
pediatrics,
in parameters?
yeah, so in pediatrics, we're seeing two main groups fall out with patients with symptoms. The ones who are irregular tend to be really severe in pediatrics. They tend to have worse symptoms, worse quality of life, worse disability scores, and they tend to be a more severe group who's needing more invasive management. But fortunately, it's a minority. Seems to be a congenital group who have these really irregular stomach states. And then there's a group in pediatrics who are interesting, who have really delayed meal responses. They eat, and it takes a long time for that activity to kick in, and those are ones who we think are more under stress and more need more psychological therapies and diet coaching and so on. So yes, the test is proving really useful in pediatrics, and there's a couple of papers coming out at the moment.
Great. And a question from Simon Dexter again, upper GI surgeon. And you answered a little bit. I know it's still early days, but he's asking about validation of allometry in post-gastric surgical patients. And I think you kind of talked to it a little bit, but what's in the pipeline?
Yeah, so yes is the answer. We've studied a number of groups. The fundoplication group is looking good. We've got a paper coming out soon on sleeve gastrectomy and one on post-pancreatic duodenectomy surgery, so patients who have had enterectomies, and I think there's another bariatric paper coming out as well. So there's been a little flurry, and there's one on esophagectomy as well, interestingly. What can I tell you about all those papers? I think at the moment we're still emerging, mapping different surgical states, but the key ones we've found have been that high frequency state linked to vagal injury, and also the cutting off the pacemaker or reshaping the stomach's physiology can lead to these dysrhythmic states. And now we're working on trying to work out which ones have maybe a polar problem in order to direct therapies after esophagectomies and so on. So it's really emerging area, but there's only 3 or 4 studies to date. Best evidence is around that high frequency.
So as you alluded to, we've probably seen about 100 patients now, and we've done 30 healthy volunteers, and we've also looking at refractory GERD patients, and we found it incredibly useful. I think one of the useful things that you showed in some of the early studies was actually identifying normal function and showing that actually this is more brain than gut, and therefore this person doesn't need a GPOM, they don't need TPN or things. Can you just talk a little bit about the importance of establishing normal function in these patients?
Yeah, exactly right, Anthony. I think, sometimes in medicine, and particularly in this field, a normal test can be the most useful test in physiology because we know there's preserved physiology. We know we can reassure the patient, get them eating, get them going. And we had a particularly pleasing study that was done in New Zealand, independent of us, where they brought back a number of patients on parenteral nutrition. There were 10 of them who they needed to restage because they just didn't know if they actually had a motility problem or not, but they'd gone down a very invasive treatment course. And after doing the test as a bit of a circuit breaker, they were able to say that 7 of them actually had normal stomach function and restaged their gastric activity and then managed to get them off PN and onto a much more improved quality of life pathway just by showing that their function was normal and providing reassurance with quite intensive dietary and psychological support. So yeah, that's been one of the most pleasing aspects of the technology.
And there's another question here from Ashish Gupta. That's a lot of hard work. He says, thanks for sharing. How does the gastric motility get altered in patients who have had fundoplication study?
Yeah, thanks, Ashish. It has been a lot of hard work, and not just by me, but by a significant team of people trying to improve this field. So yeah, thanks for noticing. How does it improve gastric motility? How does it get altered in patients who've had fundoplication? We don't really know. We haven't done a study of patients who have just had good results after fundoplication. We've only studied those with symptoms and shown that these kind of high frequency and dysrhythmic groups fall out. I suspect we're going to show that you get an earlier meal response that's more at the higher amplitude, just because you don't have that fundal accommodation as much. It's going to push everything down in the antrum, and you're probably going to get more vigorous, earlier activity and probably more rapid stomach emptying, I suspect. But someone needs to do that study, and yeah, it'd be great to see what it showed.
Yeah, and I think actually from our experience using the more basic EGG, which does have some limitations, it is still quite a useful screening tool to pick up some of the bigger abnormalities. As I say, you can kind of split it into 4 phenotypes. One is a reflux phenotype that we're quite interested in because we also do reflux testing, and we can see those people who lose that 3 CPM activity after the meal also quite often have postprandial reflux, and those people might benefit from the reflux procedure in terms of their emptying. But we can also pick up those more severe cases of pyloric outflow and disturbances as a kind of screening tool. So the question going forward really is, at what point do we do these tests as screening tools? And do they need the full panel, or are we using them to try and explain what's gone wrong afterwards, basically? So it would be quite nice to do these things preemptively in everyone, but I suppose we've got to have a pragmatic approach to this. Okay, so we've got a couple more questions here. So here we've got from any evidence of gastric remnant functioning after subtotal gastrectomy?
Yeah, so it's interesting, because often with a subtotal, you'll only really have that fundal part left or part of the corpus. And the fundus it obviously does a tone-related accommodation. And so you don't see that rhythmic gastric activity that you do in the corpus and antrum. Sometimes you see some residual corpus activity that will be active. So we haven't studied that. We've got a paper that's come out after bypass, just showing that if you bypass the stomach over time, it severely degrades its neuromuscular function. But if it's still in continuity, then that will be preserved to some degree, depending on how much of the corpus is remaining.
Thanks, Fish, for that question. And here's another one from Ashish. Are there any correlations of gastric motility problems in patients with achalasia?
Yeah, we haven't studied that at all, but I don't know, Anthony, you might want to comment on some of the reflux work you've been doing and interest in gastric problems related to the esophagus. I don't know if you've got any insights into achalasia.
Well, I guess the question is whether you get the same kind of spread of neuropathy, and that's something that we might want to look at in the future. But we certainly have no data on that at the moment. I think the interesting thing for us with the refractory GERD patients is, again, if they're not responding to it, is it because there's an overlapping gastroneuromuscular dysfunction? So, we're still analysing those data. Hopefully we'll have something ready for DDW and have some answers for that. Got a question here from Dr. Hlang. Is there any study looking at gastric allometry in patients on GLP-1 analogs? So the anti-obesity medications at the moment.
Yes, we've just finished a study on this. So we've recruited a number of patients who were healthy, put them on the drug, took them off the drug. We measured gastric emptying, we measured gastric allometry, and then before and after. And it had significant effects on gastric function that weren't isolated to gastric emptying. So it also changes some of our biomarkers. I can't quite talk about that yet because we're just in the process of submitting an abstract on it. But it's certainly the GLP-1 drugs have really interesting effects that are not just on gastric emptying, but also on gastric motility and electrophysiology as well.
Yeah,
Look
I
forward to
think when
sharing
we
that soon when we.
I think when we talked to the company about whether we could help them, get the right dose for patients to make it more tolerable, I think their opinion was actually no, we just want to give it to everyone. So once it's out
Yeah,
there, I think it's a really interesting way to look at how, whether in those people that need it long term, whether you can actually titrate the dose down to a level where you don't affect the rhythms, but you still have, the beneficial effect of it. So maybe that's kind of the next phase for it.
yeah, and actually there are about 16 new GLP-1s in development. Everyone's getting on the bandwagon, and so it may be that there's a chance to develop ones that have less significant GI side effects with the same sort of functions, because it's still the main reason that people come off drug.
And this is a great question from Ibrahim Masoodi, and one that I've asked you a couple of times. Can localization of the gastric pacemaker help to prevent dysregulation after surgery?
Yeah, really interesting. That would require more invasive devices to do more like cardiology, where you can work out where the pacemakers are and what the activity are. But in general, I think what is emerging is that we can select patients a little better by avoiding the ones who have these significant dysrhythmic states going into surgery. So if you've got a patient where you're not sure whether, it's the right move to do a sleeve gastrectomy or a fundoplication because they may have diabetes and you're just not sure what their gastric function is like. You're not necessarily going to get that from a barium study or a gastric emptying study, but we can do that with more the gastric allometry to really show that whether they have one of these severe neuromuscular profiles that the other tests are not sensitive for. And you may just want to avoid surgery on those ones altogether rather than avoid that area of the stomach as such, if that makes sense. And that's one of the areas that I hope will emerge as we get more data.
And Ken, can I bring you in on that point? Because obviously with Entera, as a neuromodulatory device in patients who've had disruption after bariatric surgery, is that something that's on the horizon for devices like Entera?
Well, at least in the States, it's kind of like it's off label, not so much in Europe. And just anecdotally talking to at least a couple surgeons, yeah, they have found after a fundoplication and that kind of nausea that you described, Greg, lots of nausea after a fundoplication. I don't think they had any electrical studies afterwards, but the Entera stimulation seemed to help. So this electrical therapy, I've said, as we establish different pathways to nausea, there are many pathways to get to nausea. As we understand that better, I think we can have a chance at understanding how this electrical therapy is working in a more sophisticated way. We need to do more in that area, and begin to determine which patients will do the best. The satisfaction rate with the therapy, it's not a cure, but patients are satisfied with that decrease, and how that decrease occurs is part of the challenge going forward to understand. Yeah. Understanding the mechanisms and then understanding how our therapy ameliorates those symptoms.
And I think that's the important thing here is not only having the diagnostic tests, but having actionable results is where we'll get the benefit. So I've got time for one more question. We've got 2 minutes left. So we've got 1 minute for this, Greg, or I think Greg is probably most suitable, is from Paul Glenn, who's a surgeon who does Entera up in Scotland. How variable is the pacemaker site in studies? Because they assume 10 centimeters back from the pylorus on the greater curve, for placement of these things. How variable might it be?
It's pretty consistent, actually. We tend to measure it more from the esophagus, the bottom of the gastroesophageal junction down on the greater curvature. It's about 5 to 7 centimeters down from the gastroesophageal junction horizontally across at the corpus is where it is. So a little higher than 10 centimeters back from the pylorus. but it's really robust. So if that area was removed, another area on the greater curvature just down from it picks up that activity and so on. And then if the whole greater curvature is removed, it moves to the lesser curvature, and usually remodels pretty well. But as I say, sometimes it's a little variable and you can get ectopics forming elsewhere.
Well, it's fascinating stuff, and thanks so much, guys, for that. I mean, I think the interest, we had over 190 people register for the webinar, so it just shows what a hot topic it is at the moment and how much interest there is there. We're at the beginning of an exciting journey, and we're starting to get some fantastic data. So I do hope that you'll get in touch. We'll do some post webinar communication. If you've got any other questions that you want us to put to Ken or to Greg or to myself, then we'll be available to do that. And there will be a link so that people can watch this offline and also communicate afterwards. So thank you so much for everyone's time. Thanks for everyone's contribution, and have a great evening. And it's time for a beer, I think.
All right. Sure. Thank you.
All right.
Happy holidays. Bye-bye. Thanks, Greg.
Goodbye.